After our last discussion on the clinical angle that we discussed diarrhea from, now we are going to start our discussions on malabsorption syndromes. I had already talked a little bit about malabsorption in our previous discussion on diarrhea and said that malabsorption is basically malabsorption. So basically when we are eating something, digestion, then absorption, then assimilation, these are the things that go on. This is basic biology, we all know this. Malabsorption means that there is some problem in the absorption of the nutrients from our digestive tract. Some disease process, something is happening that is hampering with that. So for understanding the malabsorption syndromes, for understanding the different diseases associated with it, we need to understand the basics of absorption. Now we won't go down into the nitty-gritty details of it as such, but just the basics that we need from a clinical perspective, we'll do that. So the basics of absorption. What exactly is absorption? I've already said the absorption is basically there are two things. First is absorption can be a specific thing. What does a specific thing mean? Means after digestion, which is breakdown of complex foods into simpler absorbable nutrients, that is digestion. After that, absorption occurs, which is movement of these soluble nutrients across the GI tract into the enterocytes and then into the blood vessels, from where they are carried into the different cells. In the cells when they go, that is called assimilation. Anyways, so that is one part of absorption, but sometimes absorption can also refer to, and this is just for your knowledge, I think I had also said this, digestion plus assimilation can also sometimes mean absorption. So absorption can be the grand thing as well. Sometimes people can also refer to absorption as any digestive problem, also absorption problem can be said. Okay, so don't get foxed by that. That's what I'm saying. So basics of absorption. What are the different stages in which absorption occurs? Stages. The stages in which absorption occurs is, first of all, the luminal phase. Then we have something called the mucosal stage, and then we have something called the post-mucosal stage. Luminal means this is the GI tract. Within the lumen, whatever is happening, that is luminal. Then when the nutrients, they are entering into the enterocytes, the mucosa cells, we'll see as to what these cells are, of the small intestine, large intestine, whatever it is. Mostly the small intestine, because that is where majority of the absorption of different food nutrients occurs. That is called the mucosal part, or the mucosal stage of absorption. And post-mucosal is from these epithelial cells, when the nutrients are moving into, the blood circulation or lymphatics, if it is fat, whatever. That is called the post-mucosal stage. Okay. So why is it important for us to know about these different stages? Because when we'll talk about the individual micronutrients, not the the macronutrients, that is fat, carbohydrates, proteins, and their absorption details, when we'll deal with that, we'll see that different nutrients have different defects at different stages. Okay, so a luminal defect might be there, a mucosal defect might be there, a post-mucosal defect might be there. Okay, so for that, we need to know about what these stages actually are. Okay, now let's deal a little, just a teeny tiny bit of the anatomy of the small intestine, because we need it really. As far as the anatomy of small intestine is concerned, we'll only deal with the histology of it. First of all, we know what the small intestine is, and secondly, we also know that the small intestine means it is a combination of three things. We know that is duodenum, jejunum, which together they are called the proximal small intestine. Remember always that jejunum, maximum absorption occurs. Distal small intestine, on the other hand, is ileum, which goes on to connect with the large intestine through the cecum. We know this. So another very interesting thing is, most of the absorption is occurring through the proximal small intestine, jejunum greater than duodenum. Distal ileum, or distal small intestine, which is ileum, There are only three things that get absorbed from here, and it's very important to know what these three things are. First is vitamin B12. Second is magnesium 2+, and third is bile acid. Remember these three things. Engrave these three things in your mind. These three things, vitamin B12, magnesium, and bile acids, get absorbed from the ileum. So if there is a pathology which is actually involving the proximal small intestine, these three things will be spared. Their absorptions won't be hampered. Whereas if it's a distal ileitis or some kind of a anomaly of the distal ileum, then these three things will be obviously hampered and the others will be spared. So an important clinical correlation thus appears. Now let's quickly talk about the histology. If we talk about the histology, so let me just draw a line over here. The space is actually very less. I'm not very happy with my setup, but okay, we'll have to do with whatever is given to us. Histology of the small intestine. So we know that there is a mucosal layer, there is a submucosal layer, there is a muscularis layer. This is also called the muscularis propria. Muscularis propria, and we also know that the outermost layer is called the serosa. I keep saying that we know this because this is, I think, basic biology. If you don't know this, then no problem. This is what it is. New information for you. Congratulations. So this is from the innermost. This is the innermost, and we are going up to the outermost. Now, the most important of these layers is the mucosa. So we have to talk about the mucosa in a little bit more detail. What detail? Okay. So if I say that I'm going to talk about the mucosa, let's quickly do. What does the mucosa of the small intestine have? The mucosa of the small intestine again is made up of a certain few things. What are they? First, we have something called the enterocyte. Enterocyte. What is enterocyte? Cyte means cell, and entero means something to do with the GI tract, more specifically the small intestine itself. So cells of the small intestine, this is enterocyte. Enterocytes, very interestingly, these cells, these special cells, they have something called villi. Villi. Villi is a very specific feature of the enterocytes, and these are villi are surrounded by crypts of Lieberkühn. So how exactly is the structure? So for example, the structure is somewhat like this. So suppose these individual cells, they are the enterocytes, and these enterocytes, can you see that there is a dip over here, this deep tunnel like thing over here? These are the crypts of Lieberkühn, and these individual cells, they are the enterocytes. Okay, enterocytes have villi. Okay, so this is the basically how the mucosa looks. Okay, now these enterocytes, due to the presence of this villi, what will happen is, see what is happening. I'm drawing the villi. Villi means small hair-like projections. Why these small hair-like projections are present? Very simple, so that the surface area for absorption increases. The more the surface area for absorption, the better the absorption, more the absorption can be. So we won't be missing out on important nutrients that will escape otherwise undigested, unabsorbed. That's that. Now, what happens is, because of these villi, this special appearance is called brush border. Brush border, as if it is the border of a brush border epithelium, because these are epithelial cells. Okay, so these enterocytes, they are called brush border epithelium. Done. Now let's talk a little bit about the crypts themselves. Crypt, the crypts of Lieberkühn. These crypts, they have some special cells. What special cells are we talking about over here? You can already see. Let me just label it in a different color so that you will be able to appreciate it. At the very base, these cells of the crypts, they are called Paneth cells. Paneth cells. Okay, they are at the base. And what they will do? These Paneth cells will produce immunological substances. They will produce immunological substances. Like what? Like alpha defensins, lysozymes, phospholipase A2, these things. So alpha defensin, right? Phospholipase A2, lysozymes, these things. Okay, so these are immunological cells. These are called Paneth cells. Okay, so let me make these in a different color. Okay, these cells. Okay, now at the you might say there are other cells as well. For example, there are Paneth cells that are at the base, so there is no problem with identifying them, right? And other than that, there is also mucus producing cells called goblet cells, somewhere over here. Suppose goblet cells are mucus producing. Okay, and there are also other cells called enteroendocrine cells. Enteroendocrine cells. So these three types of cells we find in the crypts of Lieberkühn. So the crypts of Lieberkühn, what we are seeing is, we are seeing these cells: goblet cells, Paneth cells, enteroendocrine cells. Done. Now this, what layer are we talking about of the small intestine? We are talking about the mucosal layer of the small intestine. So in the mucosal layer itself, we talked about the enterocytes. Now let's talk about another layer of the mucosa itself, which is called, what color did we use here? Okay, it is called B, that is lamina propria. Lamina propria. These lamina propria, they have glands, they have blood vessels. Okay, this is another layer of the mucosa. The third layer of the mucosa is a muscular layer. It is called muscularis mucosa. Please pardon the alarm going off. I know it's a little disturbing. Anyways, so this is called the muscularis mucosa. So we have a muscularis propria. Don't get confused. Okay, see, we have a muscularis propria, which is basically a layer, the muscular layer of the small intestine itself. But the muscular layer which is just belonging to the mucosa itself also has a muscular layer, that is called muscularis mucosae. This. Okay, fine. So these are the three layers. Done. Now let's go on to the okay, we can actually continue over here itself. Let's move on and let's concentrate on the second layer, which is the submucosa. Submucosa has a very interesting constituent, which is the Brunner's glands. Brunner's glands present in the duodenum. What they will do is they will secrete bicarbs, and thus it will make the duodenum alkaline. Okay, so Brunner's glands are present in submucosa. Another very interesting thing about the submucosa is In the ileum, just like in the duodenum had Brunner's glands, in the ileum there are certain patches called Peyer's patches. Peyer's patches. Peyer's patches in ileum. What's going on here? Peyer's patches are macroscopic, that is not microscopic, macroscopic. You can see it visibly. What macroscopic? Lymphoid aggregates. So basically, lymphoid aggregates are present in different parts of our body, just like lymph nodes are present. Just like that, throughout the GI tract, there are certain lymphoid aggregates present. In the duodenum, or rather, sorry, in the ileum, they are called Peyer's patches. Okay, these are macroscopic lymphoid aggregates present in the submucosal layer. And an interesting thing about the Peyer's patches is sometimes the Peyer's patches can get hypertrophied in lymphadenopathy. Not in lymphadenopathy as such, but suppose in maltoma, you can find that Peyer's patches have gotten hypertrophied. Or another interesting thing is in typhoid. Very, very interesting. In typhoid, you can see that the Peyer's patches get hypertrophied. Hypertrophied. Interesting. Highly interesting. And then we had the muscularis propria and the serosa. So we talked about the mucosa. So let me just complete the table over here. So the mucosa had enterocytes. The mucosa had what did it have? The crypts of Lieberkühn. The crypts, then they had all those other cells, right? At the base, we had the Paneth cells. Then we had neuroendocrine cells. We had the goblet cells, right? And along with that, we also had enterocytes with crypts. We had the lamina propria. And we had the muscularis mucosa. Okay. So this is basically more or less the anatomy that we need to understand the different aspects of malabsorption. Let me just quickly take out a few blank slides. Other than this, a few more rough points we can remember. They're pretty high yield points, so we should remember them. That is, within the small intestine itself, these are just random points, some other points regarding the anatomy. In the small intestine, we have special cells called the interstitial cells of Kajal. The interstitial cells of Kajal. What they do is very interesting. They are called the pacemaker cells. Pacemaker cells of small intestine. So they will actually generate the basal electrical rhythm. Okay, the basal electric rhythm in the small intestine. These are called interstitial cells of Kajal. This is an important point to remember. And another important point to remember is the small intestine mucosa that we were talking about, they are actually arranged in circular folds. Which is called plica circularis. Okay. So these are two random points that we needed to know, and some other points also you can know that the entire small intestine mucosal cells, they get shed off and they are renewed every 48 to 72 hours. These are some other things, and basically that's that. Anyways, let's move on to the business end of our deal. Okay, this is where the things get really interesting. Let's talk about the individual macronutrients that we have in our food and talk about how their individual absorption is hampered, how their individual absorption firstly occurs, and then how it is hampered at different stages. Okay, let's start with our most important macronutrient as far as malabsorption is concerned, that is fat. Fat absorption. Now you will understand why we talked about the basics first, and now we are coming to the specific things, because now you will have no difficulty in understanding the specific things. So just like we discussed in the model, absorption means there will be 3 stages, right? Luminal, mucosal, postmucosal. So let's start with fat. Fat, there will be a luminal stage. So let's start with the luminal stage of fat absorption. Luminal. Whatever is happening in the lumen of the small intestine. So, what exactly is fats? Fats means mostly triglycerides, triglyceric acids. So I can abbreviate that and say that these are triglyceric acids. These triglyceric acids, I am ingesting them in my food. They are finally coming to my small intestine. Now, do they directly come to the small intestine? Obviously not. They will pass through my mouth, they will pass through my esophagus, they'll go into my stomach, then they will pass into the duodenum and hence the small intestine. We know this. This is common sense. Why I'm writing directly small intestine should point out to you that fat absorption does not majorly occur before small intestine. Nothing much occurs. Carbohydrates, to some extent, things will start. But fats, no. Fats is majorly in the proximal small intestine, duodenum and jejunum. Let's see what happens. So we have this incredibly amazing organ called pancreas. And what pancreas will do is, these triglyceric acids in the small intestine, when they will come, we know that the pancreatic duct also opens in the second part of duodenum. If I can just bring your attention to this very interesting anatomical thing. If this is the duodenum, this is the first part, this is the second part, this is the third part. We know that the pancreas is actually sandwiched over here like this, and from here we have the main pancreatic duct, and joining it is accessory pancreatic duct, duct of Wirsung, and that actually opens in the second part of the duodenum. We know this, right? Over here. So what will happen is the pancreas will pour its secretions in the second part of the duodenum. And the fats, which are triglyceric acids, they have reached my second part of duodenum, they have reached my duodenum, they have reached my small intestine. So they will be acted upon by these pancreatic enzymes. Which pancreatic enzyme am I talking about here? Very, very important. The mastermind, pancreatic lipase. Let me use a bold color. Pancreatic lipase. Pancreatic lipase will act, leading to something called lipolysis, thus breaking down these triglyceric acids into fatty acids and glycerol. Glycerol, as far as our discussion is concerned right now, is not that important. Fatty acids, on the other hand, mighty important. Mighty important. Now, where exactly do I have the fatty acids right now? I have this in the lumen. That is why this is luminal part of the absorption. Fatty acids are present in the lumen of the duodenum, lumen of the small intestine, lumen of the jejunum, wherever it is. Now what will happen is, these fatty acids, let me go back to the black color, they will need to be absorbed into the enterocytes. What were enterocytes? Let's go back. Enterocytes were, now do you understand why we talked about the entire basic things first? Enterocytes are, yes, the brush border epithelial cells of the small intestine. They will need to absorb the fat. They will need to absorb the broken down form of fat, which is, broken down form of fat is right now fatty acids. But there is a problem here. What is the problem? Problem is, fatty acids will not be able to pass into the enterocytes. Just like that, they won't. I need to convert these fatty acids into something, and then those something can then be absorbed by the enterocytes. What is this something that I need to convert my fatty acids into? What I need to do is convert my fatty acids with the help of very, very important, which is why we have so many disorders related to bile acid. We need bile acid. We need bile acid. We also need the glycerol. And we also need some phospholipid. These three things, when combined with the fatty acids that I have broken down in my lumen, will finally form the absorbable counterpart of my fat diet, which is micelle. These micelle can now be actually absorbed by my enterocytes. And by what process do they get absorbed? Passive diffusion. That's simple. So once the micelles are formed, we have absolutely no problem. Once micelle gets formed, we have no problem, because passive diffusion means you don't even need a carrier, or you don't need a concentration, you don't need some active transporter, you don't need any of that. You just need to form micelle, and then micelle will get immediately absorbed on its own by the process of passive diffusion. Where? By the enterocytes. So look how now I have set a very clear path for the fat absorption. This is just the luminal phase. If there is a problem in any of these steps, I will find myself in a pickle, because then I will have a system where my fats are not getting absorbed from my food, and that will be a problem. So suppose my pancreatic lipase is deficient, I'll have a problem. Suppose I have deficient bile acids, I'll have a problem. So very, very, very important. Let's now go to another discussion related to this, which is related to bile acids, so that I can explain to you what will happen if we have a problem in the bile acid secretion. So how exactly is bile acid secreted? We know that bile acids are formed in the liver. But do you also know that if I give you a quantitative figure, then bile acid formation and excretion on a daily basis is approximately 500 milligrams. Not that much. But the bile acid pool in my body is close to 4 grams. How is this possible? This can only be possible if I am creating a lot of bile acids, but I'm not throwing it away entirely. I'm recycling that bile acid again. This is called enterohepatic circulation. So by enterohepatic circulation, the bile acid which I was secreting, which was helping in my micelle formation, after all that occurs, when it is being deconjugated, it is being broken down, it is again coming back to my liver, and then I'm again secreting that, and it's again coming back. This is enterohepatic circulation. We'll get into it in a little bit more detail, don't worry. Now, what exactly is the enterohepatic circulation? So for that, let's talk about the entire bile acid circulation. Suppose that, let me draw over here a line. Suppose this is my liver. I know that the synthesis is occurring over here. Synthesis. for the synthesis of bile acids, we know that, or you may not know this, we actually need an enzyme. I'm not going into the details of bile acid synthesis and all those steps, but basically we need, the most important enzyme over here is 7-alpha hydroxylase. We'll actually study this in a lot more detail when we'll study about hepatology. Right now we are in gastroenterology, so we are not dealing with the details of liver. 7-alpha hydroxylase. 7-alpha hydroxylase is the rate limiting step in the synthesis of bile acids. So the first bile acids that are formed, they are called primary bile acids. Primary bile acids. And what are they? They are cholic acid and quinodeoxycholic acid. Quinodeoxycholic acid. Okay. Now, these primary bile acids, they are actually not secreted as acids, but rather some salts. Salts of what? Salts of glycine, taurine. Glycine and taurine. And this step is called conjugation. Conjugation. Hence, these will form what we say to be bile salts. Bile salts. These bile salts will now, this is where things get interesting. See, these bile salts, now they will come into my, where is it secreted? Yes, second part of duodenum again. Second part of duodenum, D2. And in D2, we have already seen, this is D2. We have already seen what my bile salts or bile acids will help in doing, in forming micelles. So, in D2, micelles are formed. Simple. Very well. So, after this, what will happen to the bile salts? They helped in the formation of micelles. Very nice. Amazing. Now, do you remember an amazing statement that I made, and I told you to remember that? I told you to remember that. We said that proximal small intestine, almost everything is absorbed, but distal small intestine, which is the ileum, only 3 things are absorbed. And those 3 things you must remember: vitamin B12, magnesium, and oh my god, voila, bile acid. So this becomes pertinent to our discussion. Bile acids are absorbed or reabsorbed in our ileum. So after this D2 thing, the duodenum micelle formation and all of that, the bile salts will move on into the ileum, and in the ileum they will be reabsorbed. Reabsorbed, and where they will go? They will go back via the portal circulation into the liver. This is called enterohepatic circulation. But not all of the bile salts will be reabsorbed. Otherwise, we won't have any excretion of bile acid. But we already know that formation and excretion approximately 500 milligrams every day. So some bile salts or some bile acid, they will escape reabsorption, and from ileum they will go into the large intestine, into the colon. In the colon, you will learn this subsequently, or if you know this already, congratulations. Our large intestine or our colon, it's basically a harbor of colonic microorganisms, gut bacteria, lot of bacteria. Okay, so bifidobacters or lactobacillus and all of that. So these bacteria, what they'll do is they will lead to bacterial deconjugation. Bacterial deconjugation of what? Of the bile acids, forming what we say to be secondary bile acids. Secondary bile acids. And what are the secondary bile acids? The secondary bile acids are, we had cholic acid and quinodeoxycholic acid as primary. So cholic acid, the counterpart of that will be deoxycholic acid. Deoxycholic acid. and another part will be lithocholic acid. These are the secondary. So this, in a nutshell, is the entire bile acid enterohepatic circulation. Why are we studying all this? How is this pertinent to our discussion? It is very pertinent to our discussion. Do you know why? Because of this slide. We were talking about the luminal phase of fat absorption, remember? And I said to you that in the luminal phase of fat absorption, what was happening? Triglycerides were broken down in the proximal small intestine by our kingmaker pancreatic lipase. Lipolysis occurred and fatty acids and glycerols were liberated. I need to absorb those fatty acids, but unfortunately I cannot reabsorb fatty acids as they are. So I need to convert the fatty acids into micelle, and then I can easily absorb them by passive diffusion. How does this micelle formation occur? For that I need, most importantly, bile salts or bile acid. Other than that, I also need some glycerol. I also need some phospholipids. So for the micelle formation to occur, I need bile acids. And for the lipolysis to occur, I need pancreatic lipase. So now a patient with chronic pancreatitis, severe abdominal pain comes to me and I find features of malabsorption in that patient. Will I be surprised? No, I won't be. Because in a chronic pancreatitis patient, obviously the digestive enzymes of the pancreas will be disturbed. Among other things, obviously. We'll talk about pancreatitis when we'll study that in surgery. But all of that will be disturbed. So I'll find features of malabsorption, of course. I'll find features of fat malabsorption. Okay? Okay. If I have some problem in the liver, suppose, let's go to the next. Yeah. So suppose there is some problem with the synthesis. We'll actually see to this. Actually, you know what? Let's actually deal with that right now. Let's talk about the bile acid disorders, or let's actually, you know what? Let's club all of that together, whatever I was talking about, and let's talk about defects in luminal absorption. So now that we know in detail, in toto, the entirety of luminal absorption of fats along with the bile acid pathway as well, it is the easiest thing in the world now to correlate it clinically. Let's see how. You'll laugh at how easy it is right now because you are armed with the knowledge. So suppose, first I already told you one reason, which is chronic pancreatitis. Chronic pancreatitis. I already said to you what will happen. Chronic pancreatitis, no pancreatic lipase, nothing for lipolysis, fat malabsorption, no problem. Second, now all the things that I'll be writing, there will be problem in something to do with the bile acids. Suppose there is a problem with the synthesis of bile acid. How can there be a problem in the synthesis of bile acid? Where are bile acids formed from? Liver. So a pathology of the liver, for example, how about liver cirrhosis? We'll see what liver cirrhosis is, but basically liver cirrhosis means liver parenchyma is getting destroyed. It is being replaced by fibrotic nodules. And can fibrotic afunctional nodules form bile acids? Obviously not. Hepatocytes, healthy hepatocytes are being replaced by fibrotic cells or fibrotic nodules, not even cells. So how can they form bile acids? Of course they can't. So there is a defect in synthesis of bile acid in liver cirrhosis. So then I'll get a problem in my absorption of fat. Second, very interesting. See, let's go back here. There was a problem in synthesis. We already talked about that. Now, what was happening to the bile salts after they were formed? They were coming to the D2, duodenum. How were they coming to the duodenum? They were coming to the duodenum by the bile duct. We know this. This is basic anatomical knowledge. So suppose there is a problem in the bile duct. What is that? There is a problem in the transportation. How can that occur? By two diseases, which we'll study in medicine itself, in hepatology. That is primary biliary cholangitis and primary sclerosing cholangitis. These mean destruction of bile ducts. So how will the transportation of bile salts occur then? Even if you are able to form bile salts, I need ducts to actually transport them into the duodenum, and I don't have them. What will I do? Primary biliary cholangitis and primary sclerosing cholangitis. Defect in transportation. Next, let's go back to this. Suppose from the duodenum, we had bile acids, bile salt, micelle was formed, and then it was coming into the ileum, and then it was getting reabsorbed. Suppose there is a problem in the ileum itself. Suppose there is some kind of an ileal pathology for which the reabsorption is getting hampered. Now, if I don't reabsorb, all my bile salts will get excreted. And then will I have a pool of 4 grams of bile acids in my body? No, I cannot. But I need that to maintain my fat absorption for micelle formation and all that. My body cannot, my liver actually is not equipped to produce 4 grams of bile salts every day. It can only produce like 500 milligrams. So if I'm at a loss for reabsorption of bile acids, then obviously I won't be able to form micelle. And thus there will be a luminal defect, luminal absorption problem. So the fourth problem is basically reabsorption. Reabsorption problem means that there is some pathology in the terminal, or rather in the distal small intestine, from where bile acids are absorbed, which is that ileum. So now you will later learn, we'll talk about this actually in a subsequent video, about very, very important pathology, which is called Crohn's disease. Crohn's disease. Okay. Crohn's disease is something which majorly affects the ileum. And another very, very important pathology which majorly affects the ileum is TB, tuberculosis. So these both lead to ileal dysfunction and hence will affect the reabsorption of bile salts. Now, another last but not the least. Suppose what was happening? See, the colon had deconjugating bacteria. Suppose the colon does not have deconjugating bacteria, or rather the colon does have deconjugating bacteria, but along with the colon, along with the large intestine, my small intestine also for some reason has deconjugating bacteria. Will that be good? No. If my small intestine, if my proximal small intestine, or before the distal small intestine, that is the proximal small intestine itself, before the bile acids have a chance of getting reabsorbed back into the enterohepatic circulation, they encounter deconjugating bacteria in the small intestine lumen itself, then what will happen? They will get deconjugated into secondary bile acids. And can the secondary bile acids be reabsorbed? No, because where were the secondary bile acids being formed? In the colon, and then they were being excreted out. So obviously they are not being reabsorbed. They won't be able to get reabsorbed. And so what will happen? I will lose my bile salts. And so the bile salts won't be able to form micelle. This interesting thing that I said about small intestine having deconjugating bacteria, this is a very special entity, a disease, which we'll talk about later, called SIBO. SIBO means small intestine bacterial overgrowth. Small intestinal bacterial overgrowth. Okay. So if small intestine itself also has the deconjugating bacteria, then we'll have this problem. So now see, is this in any way problematic? Tell me. No, of course not, because we know about the entire the entire physiology of luminal absorption. So it was absolutely, there is no problem in understanding these individual defects. Okay, so this is more or less the luminal absorption. Now, look, we haven't completed the story yet. We are still talking about fat absorption, and we haven't yet reached the epitome, or the zenith, rather, the climax of our story. This is just the luminal phase of absorption. But don't worry, this was the longest or the most needed to be discussed, the most phase. So other phases they're not that important, or rather they're not that lengthy. So what is the next phase? After luminal phase, there will be the mucosal phase, where the enterocytes, they will absorb the micelle. So what happens after the micelle gets absorbed by the enterocytes? That is the story that we are going to deal with next. So this is the, what had I used for luminal? Okay, blue. So let's go back. Let's actually keep the decorum. This is the mucosal phase. Now, I'll give you a cheat code here. I will give you a cheat code for understanding mucosal phase of fat absorption. Do you know what that cheat code is? Basically, what will happen is, like, you don't need to know the details of it, and there are not much any details to actually discuss over here. Mucosal phase of fat absorption is basically just enterocytes absorbing the micelle being carried over, and then not much happens. They're again broken down into fatty acids and the glycerol, and then the fatty acids itself, we'll see that in the next step, that will form chylomicrons, and then it will be absorbed into the lymphatics. That is the post mucosal phase. So what I'm trying to say, don't get confused. You understood the luminal phase, na? Okay, stop there. Now just remember that the mucosal phase of fat absorption does not have much. You don't need to remember anything. Just remember this one thing. Mucosal phase of fat absorption, as far as the defect of that is concerned, what will the defect of the mucosal phase deal with? We talked about the defect of luminal phase in so much detail. Bile acid problems, chronic pancreatitis, SIBO, this, that, all that. Defect in mucosal phase of fat absorption means that there is some defect in the small intestinal integrity. Do you understand what I mean? If there is some disease which involves the small intestine enterocytes, and that disease is destroying the integrity of those cells such that those cells are not able to function. Suppose I go and destroy someone's home, then will that person who was residing in that home be able to live there? Obviously not. Will that person be able to, suppose that person was conducting some tuitions or something from their home, will he or she be able to conduct tuitions anymore if I go and destroy their home? No. Will that person is, suppose that person used to deliver handmade chocolates. He used to make handmade chocolates from his home. He used to deliver it from his home. Now, if I go and destroy his home, will he be able to deliver these handmade chocolates anymore? No, he won't be able to. What do I mean by that? What is the analogy over here? What I mean to say is, no enterocytes, no fat absorption. So if the enterocyte is not there, if the enterocyte integrity is lost, fat absorption will be hampered. But do you also need any more intelligence to think and say to me that if the enterocytes are not there, or if the enterocyte integrity is lost, dude, will protein, will carbohydrates, won't they be affected as well? Yes, of course they will be. Yes. So the catch point over here is, whatever I am going to talk about as far as the defect in the mucosal phase is concerned is global. That is, all the nutrients, proteins, carbohydrates, and fat, which we are discussing right now, all of them will be affected. Because at the end of the day, if you don't have the house, how will you conduct business? Up to now, what we discussed was specific defects. Like, I don't have a car right now, so I won't be able to deliver this product. I don't have my bike right now, so I won't be delivered that product. Okay, or there is a lot of rain outside, so that's why I won't be able to deliver. But if I destroy your entire house, then you won't be able to deliver anything. That is the outcome, or that is the conclusion that I want to draw from this. Hope not lengthy conversation that we had. So anyways, what are the problems that we can have as far as defect in the small intestine integrity is concerned? This is very simple. 3 diseases: celiac disease, Whipple's disease, and tropical sprue. Tropical sprue. Okay, these 3 together, they form the basis for what we say to be global malabsorption, and we will have detailed discussion in a later video on each of these individual topics, because they are very, very important. Celiac disease, Whipple's disease, and tropical sprue, very, very important, each of these individual things, and we'll deal with them in individual topics, in individual videos. These 3 will lead to defect in the small intestine integrity, and they will lead to something called global. Global means all the nutrients are actually getting affected over here. So that's the problem. Okay, this is more or less the mucosal phase of fat absorption. Now, what is the post-mucosal part? We know that there are 3 counterparts. There are 3 phases of absorption. We know that: luminal, mucosal, post-mucosal. So now we are coming to the last phase of fat absorption, post-mucosal. That is, after the fat has been absorbed into the enterocytes, and from there, how will the fat be reaching the peripheral circulation and then into the cells? That is the entire part of post-mucosal. So what is happening? See, what is happening is, we have these fatty acids. These fatty acids, after they were absorbed by the enterocytes, for being absorbed into the circulation, they need to form something called chylomicron. Chylomicron. Now, chylomicrons, for their formation, we need a process, and that process is called esterification. So, just like we needed a process of micelle formation for the fats to be absorbed, for the fats to reach the peripheral circulation from the enterocytes, we need esterification, and for the fat to form chylomicrons. For esterification, we need again glycerol, and very, very important, a special protein called ApoB48. Not exactly a protein, it's a cofactor. ApoB48. Very, very, very important. Now, these chylomicrons, what will happen is, they will be loaded up into the vessels. And what vessels are, this is basic biology, what vessels are fat transported in? Are they transported in blood vessels like proteins and carbohydrates? No. They are transported via lymphatics. Lymphatic channels. What lymphatic channels are we talking about over here? Intestinal lymphatic channels. Intestinal. Transport via intestinal lymphatic channels. Okay. Now, this is the physiology. Now let's talk about the pathology. Just like we had the the luminal defects, over here also we'll have some defect in each of these steps. There are basically 2 steps. So there will be 2 defects over that we have to talk about over here. See how easy it is. See, if there is a problem with esterification over here, this is called A beta lipoproteinemia. A beta lipoproteinemia. Very, very interesting. If there is a problem with the esterification reaction, basically what happens is ApoB48 deficiency occurs. Okay, ApoB48 deficiency occurs, We'll actually talk about this later. So for that, what will happen is acidification won't occur, and for that chylomicrons won't be formed, and so malabsorption of fat. I won't get fat in my cells. Okay, this is one defect. The second thing that can happen is if this transport via intestinal lymphatic channels, for some reason this is hampered, and this happens in something called intestinal lymphangiectasia. Intestinal lymphangiectasia. Okay, so these are the two defects of the post mucosal part of fat absorption. These two defects we'll talk about in our next video, and I think we should end our video with this. So what did we learn in this video? We learned, basically we completed the entire fat absorption. We learned about the physiology of fat absorption. We learned about the various pathologies of fat absorption and malabsorption, and just a little bit more we'll need to study, and then we'll be able to end this entire discussion. Okay, so hopefully this video has been of some use to you, hopefully, and thank you very much.